All right, thank you again. I'm going to talk mostly about appropriate imaging because I see there's a talk following me by Dr. Cholera from MGH. He's a pretty dynamic speaker, very smart man. So I'll let him get into dose optimization. And the dose optimization piece, I'll talk about the appropriate imaging for pregnant patients with acute abdominal emergencies. Oops. I'm going to cover three major entities in the interest of time: acute appendicitis, urolithiasis, and trauma. And the reason I also chose these three entities to cover, beside the fact that they are the most common acute abdominal emergencies in the pregnant patient, is that there is a possibility that imaging each of these situations could entail CT. For other entities such as cholelithiasis, cholecystitis, or choledocholithiasis, those are very well imaged just with ultrasound or with MR, and generally do not require CT. Starting with acute appendicitis, it is the most common non-obstetric surgical emergency in pregnancy. You're more likely to perforate, a pregnant patient is more likely to perforate versus a non-pregnant childbearing age woman. This is mostly because the clinical diagnosis is challenging, especially in the second and third trimester, and the clinical presentation can often be a little challenging in pregnant patients. If perforation does occur, it is associated with a higher fetal loss rate. So imaging is really critical for timely and accurate diagnosis, because what we want to try to avoid is perforation. Now, we also want to avoid a negative appendectomy, so we need a precise diagnosis, because appendectomies are also associated with a higher fetal loss rate. So delaying diagnosis can result in increased risk of perforation, and which in turn can result in increased risk of fetal loss. So I've created these tables from the ACR appropriateness criteria, where I've compared adults to pregnant patients. Now, if you're an adult non-pregnant, a CT abdomen and pelvis with IV contrast is the most appropriate test. Other exams listed may be appropriate, but typically it is standard of practice in non-pregnant adults to just do a CT abdomen and pelvis with IV contrast. If you're, however, pregnant, then the most appropriate tests are going to be a right lower quadrant ultrasound and an MR of the abdomen and pelvis without IV contrast, and CT with or without IV contrast may be appropriate, but is generally not first line. And MR with contrast is not appropriate because gadolinium is not used in pregnancy. So if we look at the results of the East multi-center study, which was 28 centers, this was published in 2020, and they looked at the type of imaging. This is retrospective. It's a retrospective study which looked at what was actually being done in women of childbearing age, 18 to 54 years, who had a suspected or confirmed diagnosis of acute appendicitis. So this is all women, and of these 969 non-pregnant women and 41 pregnant women. If you look at the non-pregnant women, CT is the most widely used imaging exam. If you look at pregnant women, MRI, and a combination of MRI and ultrasound, generally MRI done following ultrasound is the most widely used exam, followed by MR alone, followed by ultrasound. And CT is quite infrequently used as first-line imaging or the only imaging in pregnant patients. But even though ultrasound is first line, what are the challenges of ultrasound? In this very solid study that was done out of the University of Washington, that looked at 99 consecutive patients, greater than 14 weeks of gestation with right lower quadrant pain between 2001 and 11. These patients were evaluated initially, patients who were evaluated initially or exclusively CT or MR were excluded. The mean gestational age was 23 weeks. Mean maternal age was 28 years. Appendix was not visualized in 97%. And this is at an academic medical center with well-trained sonographers. Appendicitis was diagnosed in 2 of the 3 patients in whom the appendix was visualized. A total of 8 patients underwent appendectomy. 7 of those were positive for appendicitis. So in total, ultrasound diagnosed appendicitis in only 29% of patients. So that's sort of the challenge in ultrasound, and ultrasound did not diagnose appendicitis in about 71%. In the same study group, CT was done in 11 of these 96 patients in which the appendix was not visualized. Once the CT was done, appendix was visualized in 10 of those 11, 2 were positive for appendicitis. MR was done in 9 of 96 patients in which the appendix was not visualized. The appendix could subsequently be visualized in 6 of these patients, for 67% of these, and they were all considered negative for appendicitis based on the MR imaging. Another study done by Frank Miller's group out of Northwestern was a retrospective study. Over 10 years, they looked at 471 pregnant patients with suspicion of appendicitis. These patients underwent ultrasound as their initial imaging study. The appendix was visualized on ultrasound in only 16%. They went back and applied BMI cutoff values, and using BMI cutoff values of 36, 30, and 26 for the first, second, and third trimesters would decrease the non-visualization rate by 16%, 35%, and 67%. So in this study, they did show that there was a correlation in terms of the BMI and the non-visualization rate. So if you used index BMI cutoff values that they suggested, it would reduce the number of primary ultrasound examinations by 35% and increase the rate of visualization by 6%. So what this really tells us that if we use these index values, then if you use these BMI values, that cutoff values that they've proposed for the different trimesters, then you can actually skip ultrasound in those patients and move straight to MR. Essentially, you're saving time, because you're going to end up with the non-visualized, very high chance of ending up with a non-visualized appendix. So there's lots of studies in the last few years that look to and they looked at published studies between 2013 and 2021. I like this meta-analysis because it is because in this sort of time range, most scans have been done on MR scanners that are 1.5 T. And also the majority of studies that were included in this meta-analysis were done in the United States. So if you look at this meta-analysis, you get a pooled sensitivity of 92%, a specificity of 98%, which is quite excellent, a positive likelihood ratio of 29.52 and a negative likelihood ratio of 0.1. The diagnostic odds ratio was 373, which is pretty excellent at diagnosing appendicitis, and MR had an accuracy of 99% for diagnosing acute appendicitis in pregnant women. Since it's a radiology talk, I'm going to show some examples. To the left is what a normal appendix looks like. Looks like a black worm. Typically does not contain fluid, and there's no straining around it. It's generally typically collapsed, so that's what a normal appendix looks like. To your right is an imaging example of acute appendicitis. You can see a thickened wall. You can see fluid within the lumen. On the fat-saturated images, you can see periappendiceal fluid and edema. So this is pretty typical for acute appendicitis. The algorithm or the protocol for MR is typically a triplane T2 with and without fat sat. T1 weighted images can be quiet, but they're optional. Gadolinium is category C, typically not given in pregnancy, and 3T is generally not used in pregnancy. It's another imaging example with similar findings: a thick-walled structure, a blind-ending a tubular structure in the right lower quadrant containing fluid with some periappendiceal fluid. So this was a 23-year-old pregnant female who presented with right lower quadrant tenderness and fever. An initial ultrasound that was done was actually negative. It was claimed that the ultrasound was not seen. An MR was subsequently done, which was just shown over here. And after we looked at the MR, the appendix was in quite a favorable location. So I actually went back and brought the patient back to do an ultrasound to see if I could identify the appendix. And then this retrospective ultrasound that was done following the MR, or repeat ultrasound following MR, we were able to identify the blind ending appendix, which measured 10 millimeters and was non-compressible. A couple other examples. The one on the left has this sort of black dot in the center of the thickened appendix. That's an appendical lead. Typically, patients with appendicitis do not have any air in the appendix because the appendix is fluid filled, so that's an appendical lead. And here's another imaging example on your right side showing appendicitis. How about CT for appendicitis? CT has very high diagnostic accuracy in non-pregnant patients as well as in pregnant patients. However, CT should be performed only if the ultrasound and the MRI are non-diagnostic, if MR is contraindicated or unavailable. With this caveat in mind, it should not be withheld if a delay in diagnosis can result. You need to keep the radiation dose low. However, I do believe that if you're going to do it, you need to perform a diagnostic exam and only once, and IV contrast is generally needed and should be given. I don't think iodinated contrast is that big, is not an issue in pregnancy, and should not, iodinated contrast for CT should not be withheld. If you're going to do a CT, then it is best to get a diagnostic exam, so you're getting an exam only once. So IV contrast should almost always be used. Here's an example, typical, again, typical imaging findings of acute appendicitis in a pregnant patient in the second trimester, fluid-filled appendix, the right lower quadrant. And this is in CT. So appendicitis in pregnancy, it's key to avoid a delay in diagnosis. Ultrasound is the initial study just because it's fast and it's easily accessible. Perform MR if the ultrasound is non-diagnostic. Be cognizant of, you can use the BMI cutoff values that are proposed in Frank Miller's study and proceed straight to MR. CT should be avoided when possible. We need to optimize the dose. So here's the proposed algorithm. So pregnant patient with symptoms concerning for appendicitis, do the ultrasound. If positive, appendectomy. If negative or non-diagnostic, move to abdominal MR. If the abdominal MR is positive, move to appendectomy. If the abdominal MR is also indeterminate, consider CT. If the abdominal MR is negative, no further imaging needed. Let's move on to stones in pregnancy. Again, I've made these tables to show the appropriateness, what the appropriateness criteria would do for a non-pregnant adult versus a pregnant patient. So in a non-pregnant adult, CT abdomen and pelvis without IV contrast would be the most appropriate exam. And there's some debate about doing ultrasound for stone disease in non-pregnant adults. KUB generally may be appropriate, and MR is generally not used for this purpose because most of these patients present to the emergency room, and so it's not used in non-pregnant patients. However, an MRU without IV contrast may be appropriate in the pregnant patient. And ultrasound, again, is the first line starting test for patients, for pregnant patients, and I'll talk a little bit more about that. And a CT ab-pel without IV contrast, that's what the ACR appropriateness criteria states, may be appropriate. I would actually caveat this a little bit. And even in a stone patient, I would use IV contrast. And the reason I would do that is alternative diagnosis, because you can still pick up a stone on a portal phase CT in the ureter. But it is an opportunity, by giving contrast, it is an opportunity to pick up an alternative diagnosis that because stones can mimic other entities such as Crohn's disease or acute appendicitis at times. So if you're going to do the iodinated contrast is not that big of an issue in pregnancy. So if you're going to do a CT, even in stone disease, I recommend using IV contrast, low-dose IV contrast. You don't want structures to be too bright, and stones can be picked up on portal phase CT. They're just not, it's not necessary to give the contrast, but in this situation, you don't want to repeat the exam. So role of ultrasound. Now, the good news is that majority of these patients can be managed conservatively, because 50 to 80% of urethral stones, especially stones smaller than 4 millimeters in size, are going to pass spontaneously. Stones between 4 and 6 millimeters of size, 50% of those are going to pass spontaneously. Now, the challenge in pregnancy is physiologic hydronephrosis. That can occur in up to 80% of pregnant women, right side greater than left, typically starts second trimester, and then gets significantly more in the third trimester. So one caveat over here, knowing that the physiologic hydronephrosis starts in the second trimester, if you do an ultrasound in a patient in the first trimester and they have symptoms of renal colic or painful hydronephrosis, and there's hydronephrosis, then this is not going to be physiologic hydronephrosis because they're in the first trimester. And then there's a high suspicion for stone disease in that patient. Ultrasound overall has a low sensitivity for detecting stones in the ureter. It is good for detecting stones, not 100%, but it's good for detecting stones in the kidneys, but generally very low sensitivity in the ureter, especially for the mid and distal urethral segments. However, please note that a negative ultrasound can be useful. So if there's no hydronephrosis, the patient's having flank pain or lower quadrant pain, then you got to start thinking of an alternative diagnosis. Now, one technique I personally find very useful, and I've done that a few times, is doing an endovaginal ultrasound to identify a UVJ stone in a patient who has hydronephrosis and the appropriate symptoms. Now, what has been reported in the literature is the role of resistive indices. It has been reported that your average resistive indices is greater than 0.7, or a difference of 0.06 to 0.1 in the mean RI values between kidneys has been touted as a highly specific and sensitive measure for acute obstruction. However, careful with this. This really depends on the skill set of the sonographer. Results have not been replicated in subsequent studies. These are 2 papers that reported this that came out in the early 90s. And in practice, personally, I have not found this to be very reliable. So that's something to keep in mind. Now, the absence of urethral jets is a useful ancillary information, although you can have an absent urethral jet in a patient without an obstruction. So a lot of ancillary information, hematuria, their clinical presentation, their UA, the trimester of the pregnancy, the information from the ultrasound. You've got to put all of that together, to try and figure out if the patient indeed has stone disease or physiologic hydronephrosis. We bring in MRU as an option. This is done without contrast. Essentially, these are heavily saturated T2-weighted images. This is static MRUs. They have high sensitivity for diagnosing hydronephrosis in the point of transition. The pitfalls are obviously the flow artifacts can mimic stones. Suggestive of urolithiasis would be asymmetrical renal enlargement, edema of the kidney as evidenced by slightly increased T2 signal. Perirenal fluid, I believe, can be quite specific. And if you can actually identify a filling defect in the ureter, then you can have a diagnosis. You've got to be careful of flow artifacts, which can mimic stones. What is suggestive of physiologic dilatation is smooth tapering, and typically the physiologic dilatation, the tapering will occur at the middle third of the ureter, right by the uterus. So, example on your left is physiologic dilatation, right where when the ureter hits the gravid uterus, it's a smooth tapering. So that's physiologic hydronephrosis on MRU. Images on your right. Is a CT in an early pregnancy. There's hydronephrosis. On the right side, there's perinephric straining, there's asymmetrical renal enlargement, and obstructive calculus is identified in the distal ureter.
Hey, Dr. Lamba, Carly here. You have 5 minutes to wrap up.
Oh, beautiful.
Thank you.
So another example over here of urolithiasis, stone in the mid-ureter in the pregnant patient. Example on your example on your left. Example on your right is perinephric edema seen in the T2-weighted images and filling defects seen in the distal ureter. So positive example of urolithiasis with MRU. Finally, getting on to trauma. So in trauma is where a CT is going to be considered appropriate, although an ultrasound is also appropriate in trauma. and a CT with IV contrast is what's going to be. So trauma is where CT tends to be used. Obviously, fast scans have a role. I'm going to show some an important study with respect to fast scans that came out of UCSD in 2001. Still a pretty solid study. 1,047 patients, and they looked at free fluid that was in the cul-de-sac, free fluid that was in the abdomen, and free fluid in the abdomen pelvis. And obviously, if the free fluid was in the abdomen pelvis, had a high correlation with injuries in general, and high correlation with surgical injuries, like injuries that required the patient to go to the OR. But they also showed in the study if the free fluid was isolated to the cul-de-sac, then the difference. It was likely that this was physiologic. There was low likelihood of having a solid organ injury in patients where the free fluid was isolated to the pelvis. So that can be a very useful piece of information. So the most concerning would be where there's free fluid both in the abdomen and pelvis on a fast scan, followed by free fluid only in the abdomen. And the least concerning is free fluid isolated to the cul-de-sac. And in those patients, the authors recommended just a clinical follow-up should suffice on these patients, and no further imaging with CT would be warranted. Here's just an algorithm that we use at UC Davis for scanning CT for pregnant patients. And you can review it later. So this algorithm is made so that we are doing appropriate scanning, and that we're not just doing we have a term we call CT rectum to tectum that we do for all trauma patients, but we try to avoid that approach for pregnant patients. Just some examples on CT. Here's an example of a pelvic bone fracture and soft tissues injury in the right on the right side, the right iliac bone. Images on your right, and there's also fracture of the baby's femur. Another example with a gunshot in the pelvis, a gunshot injury where the bullet is identified. And fortunately, the bullet did not make it to the uterus or the colon. So this patient could be managed conservatively and went on to have a normal baby. And an example on your lower right is an example of femur fracture in the fetus seen on ultrasound. Another example in trauma CT shows large extraperitoneal hematoma, pelvic fracture, extravasation in the soft tissues. This is a very interesting example. I love this image. It's a pregnant patient, second trimester, fast scan was done. And the fast scan here in the left upper quadrant, upper two images, shows an echogenic area. So when the fast scan was done, there's this big echogenic area, and they said, well, this is a huge hematoma. So based on that, the patient was clinically stable, hemodynamically stable. The mechanism of injury was not significant, but based on this finding, the patient went to CT. Lo and behold, massive AML in the kidney. And that's going to appear as, and there's no trauma in this patient. And that's going to appear echogenic on the ultrasound. That was the echogenic area that was being seen on ultrasound. So very interesting case. Trauma, role of MR, no published study. Generally, access to MR scanners is limited. Challenges are MR safety screening in trauma patients who sometimes may not be responsive. Monitoring these sick patients in the magnet is not easy because they have a lot of monitoring devices that may not be MR compatible. Long scanning times, which generally is not optimal for trauma patients. There's artifacts created by fetal and bowel motion, and we cannot use gadolinium. Obviously, MR has limitations. You can't detect free air. It's limited for bowel injury. It's limited for detecting extravasation, both from the blood vessels and from the urinary collecting system. And it's also limited in evaluation of pseudoaneurysms. So MR is quite limited. Although here's an example of a pregnant patient, right lower quadrant ultrasound showed this kind of complex heterogeneous collection. And subsequent MR was done that showed this is a large hematoma in the iliacus muscle. I'm not going to get too much into this because Dr. Caldera is going to kind of blow this out of the park. Dose reduction strategies. We use the lowest dose for the scout exam, never scan at 140. What we do is we do use dose modulation, but we do cap the upper MA limit, because these pregnant patients, if you use dose modulation, don't cap the upper limit, because the belly can be quite big in some cases, and then the dose modulation can kick in pretty hard. So I generally, my strategy is to cap the upper MA limit. If that option is available in your scanner, it's not available on all scanners. I use the widest detector mode that's available, and never scan multiple phases. With the exception of, we may rarely do a delayed low dose through the region of interest, only if there's a suspicion of upper urinary tract injury. And we would not do a CT cystogram on these patients. We would actually prefer getting a conventional cystogram, so no multi-phase scanning for pregnant patients. It's just a UC-DMC suggested protocol. I'll let Dr. Calder get into the details of this. We do use, we have older scanners, so we have Acer. We set the upper limit at 300, a noise index of 18. For Siemens, we set the reference mass at 160. We use a Sapphire strength of 2. And here's an example, 17-week pregnant patient MVC using one of our 64 detector scanners, a KV of 120. Noise index was set at 18. This is an older example. This is when pre-Acer. And we had one of our physicists calculate the fetal dose because the patient wanted to know what that was, and it was 0.7 rads. So it's an example of low-dose CT. I don't believe in dropping the dose too much. There are several exciting techniques for dropping the dose that I'll let Dr. Calder talk about that. I know he's going to devote a whole half hour to that. With that, thank you for having me.